All right. There we go. Welcome everybody to our colloquium series presentation. Very excited. We'll be flogging it. Very excited audience. Very excited to be having my colleague and friend Leslie Carlton, who is going to be presenting to us today on exploring dimensions of medically assisted suicide. This is part of the master's work that she did and was one of our first honors graduate students back in the fall. So well done, Leslie. There should be some time afterwards for questions, but I think that's it. Yeah, take it away.
Thank you, Dr. Nikeshi. So, for those of you that don't know me, my name is Leslie Carlton. I graduated in December, and this is my thesis topic that I completed. So, my thesis was exploring the ethical, psychological, and social dimensions of medically assisted suicide. This topic grew from a curiosity of the laws regarding medically assisted suicide after the reports in 2024 from Switzerland, where a 64-year-old American woman sought the use of a 3D printed, what they call a Sarcos pod. She was the first person to die in pods, and because they were not legal, even though Switzerland has medically assisted suicide, the pods were not legal. They were all indicted and charged with aiding and abetting suicide. Which led to further research on programs that we have here in the United States and Canada and other countries in the UK. I wanted to understand how end-of-life decisions are shaped not only by law and medicine, but also by lived experience, cultural context, and ethical framework. Medically assisted suicide, or MAS, is one of the most ethically and emotionally complex issues in healthcare today. Since my research began in 2024, the legalization of MAS has grown from 11 states to 13, with an additional 15 states that have current bills in review legislation. This is forcing patients, families, providers, and policymakers to confront profound questions about autonomy, suffering, dignity, and justice. Additionally, the global relevance of MAS was highlighted by the case of Alice and Ellen Kessler, the iconic German twin entertainers who died together by assisted suicide in November of 2025. At the age of 89. They planned their deaths for over a year, joining Germany's Society for Humane Dying and stipulating in their wills that they wanted to go away together on the same day just as they could come into the world. Their decision was legal under Germany's assisted dying laws, which require voluntary self-administered medication. This case underscores the intersection of autonomy, cultural values, and legal framework. My work situates MAS as the intersection of bioethics, psychology, and communication, asking how do patients, family, and providers experience MAS, and how can policies and practices honor lived experiences while safeguarding against coercion. My thesis examined the ethical, psychological, and social dimensions through comprehensive literature review grounded in bioethical theory. Drawing on interdisciplinary scholarships, the study explores how autonomy, malfeasance and non-malfeasance, and justice inform end-of-life decision-making across diverse cultural, clinical, and relational contexts. My three key questions were how do terminally ill patients perceive MAS in relation to their autonomy and quality of life? What psychological effects do families experience when supporting a loved one's decision for MAS? And how do healthcare providers navigate the moral and ethical dilemmas they encounter while assisting patients with MAS? My review integrated feminist bioethics, disability justice, and intersectional analysis to critically assess how MAS decisions are shaped by caregiving dynamics, systematic inequities, and emotional suffering. Findings suggest that emotional relief, ethical distress, and perceived burdensomeness significantly influence MAS choices, while access, disparities, and cultural dissonance complicate ethical evaluations. My thesis underscores the need for cultural, responsive, justice-oriented MAS policies that honor lived experience and safeguard against coercion, offering a foundation for future research and ethical dialogue in health communication. The bioethical principle theory, as articulated by Bishop and Childress, remains foundational in evaluating the ethical dimensions of medically assisted suicide. The four principles, autonomy, beneficence, non-malfeasance, and justice, provide a structured lens for assessing patient rights, provider responsibilities, and systematic equity. In the context of MAS, these principles offer a framework for navigating the moral complexities of end-of-life decisions, especially when clinical, emotional, and cultural factors intersect. Autonomy is often framed as individual choice, yet feminist bioethics and disability justice remind us that autonomy is relational, shaped by caregiving, stigma, and systematic inequities. Beneficence and non-malfeasance are in tension, relieving suffering and aiding assisted death, but this challenges medicine's healing role. Justice requires an equitable access, but disparities in healthcare income geographical complicate whether MAS is truly a choice. By integrating these principles with intersectional analysis, my study challenged dominant narratives of choice and dignity, showing how MAS decisions are embedded in relational and structural context. To explore these questions, I employed a mixed methods design combining qualitative and quantitative approaches. The literature review synthesized interdisciplinary scholarship across bioethics, psychology, sociology, disability studies, and health communications. Using thematic coding, I organized findings around economy, beneficence, non-malfeasance, and justice. To situate the study with public accessible discourse, a comprehensive analysis was conducted using material from Dying Dignity, including Facebook posts and blog entries. These sources were chosen for their narrative richness, ethical framing, and sustained engagement with end-of-life issues. Thematic coding was applied to identify recurring ethical motives, which particular attention to how language reflected values such as autonomy, justice, and beneficence. These four dominant themes emerged: choice, emphasizing personal agency and self-determination; availability, highlighting access disparities and systematic barriers; dignity, centering respect, identity, and relational integrity; and pain, foregrounding suffering, relief, and compassionate care. These frequencies illustrated the ethical salience of those concepts in public discourse and provided a scaffold for developing both the interview guide and my book. I then conducted 12 in-depth interviews with participants intentionally selected to reflect diverse cultural, religious, and socioeconomic backgrounds. Using purposive and snowball sampling, inclusion criteria emphasized direct experience with medically assisted suicide and willingness to engage with ethical and emotional dimensions. My participants ranged in age from 22 to 73, with a balanced gender representation, varied educational attainment, employment status, marital situations, income levels, and religious affiliations. Most resided in the U.S. Two of my candidates were in Canada, allowing for cross-border reflection on policy and cultural variation. The justice-oriented sampling strategy amplified voices from communities historically marginalized in healthcare decision-making, including those facing financial strain, stigma, and limited access to palliative care. My interviews were conducted via secure video conferencing lasting 60 to 90 minutes. The guide was structured around bioethical principle and included scenario prompts to explore values, tensions, and moral boundaries. Ethical safeguards include IRB approval, informed consent, and confidentiality. The data was analyzed using reflective thematic analysis with autonomy, limitations, and non-malfeasance, and justice serving as a primary code framework. Subcodes such as family burden, anticipatory grief, moral distress, communication gaps, and cultural framing enriched the analysis. My coding was conducted in Atlas software with discrepancies resolved through ethical dialogue and consensus. Analytical memos, documented decisions, emotional reactions, and ethical tensions, ensuring transparency and reflexivity. This mixed method approach allowed me to balance depth of experience with a span of systematic analysis, ensuring rigor while centering both individual voices and structural conditions. So my key findings for justice. Justice calls for the fair distribution of healthcare resources and equitable treatment of all patients. Ethical concerns regarding MAS often center on disparities in access, particularly among marginalized communities, where financial constraints or inadequate medical support may influence individuals' decisions to pursue assisted dying. Justice requires that MAS is available to all eligible individuals, regardless of socioeconomic status, geographic location, or identity. As discussed in the Disability Justice and Intersectionality section, systematic inequities may lead some individuals to view MAS as their only viable option. This raises concern about whether MAS is truly a choice or a reflection of structural neglect. Ethical frameworks must address these disparities by ensuring access to palliative care, mental health services, and culturally competent support. Justice also intersects legal and policy debate. For example, Canada's expansion of MAS eligibility to include non-terminal conditions has sparked concern among disability rights advocates who argue that vulnerable populations may be disappropriately affected. Ensuring procedural safeguards, transparent eligibility, and criteria along with inclusive policy development, is essential to uphold justice with MAS practices. Justice and equity and access. Justice also intersects legal and policy debate. For example, I think I put this in there twice, I'm sorry. In the United States, MAS is legal in several states under laws like Oregon's Death with Dignity Act, which requires terminal illness, mental competence, and voluntary request proceedings. These laws emphasize autonomy and informed consent, but implementation varies by state. California, Washington, Vermont, and Colorado have adopted similar statutes, while other states continue to prohibit the practice. Advocacy efforts have played a pivotal role in shaping MAS legislation and public discourse. Organizations like Compassion and Choice in the U.S. and Dying with Dignity in Canada mobilized public support, lobbied for legal reform, and provided education on end-of-life options. These groups emphasize autonomy, dignity, and transparency, often using personal stories to humanize policy debates. Autonomy is understood not merely as individual's choice, but as a regional agency, shaped by access, support, and the ability to make decisions free from coercion. Beneficence and non-malfeasance are interpreted through participants' narratives of suffering, relief, and emotional burden. Justice is examined through structural barriers, disparities in access, and the cultural framing of dignity and death. These principles inform every stage of the research process, from data collection to analysis and interpretation. To ground the study in public accessible discourse, a content analysis was conducted in Dying with Dignity. These sources, primarily Facebook posts and blog entries, were selected for their narrative richness. The analysis employed thematic coding, identified recurring ethical motifs across posts, with particular attention to how language reflects values such as autonomy, justice, and beneficence. Four dominant themes: choice, emphasizing personal agency; availability, highlighting access; dignity, centering through respect; and pain, foregrounding suffering, relief, and compassionate care. They not only illustrate the ethical salience these concepts in public discourse, but also provide a foundational scaffold for developing an interview guide and codebook. These themes were further refined into subcodes such as family burden, anticipatory grief, moral distress, communication gaps, and cultural framing. Coding was conducted using Atlas qualitative software. Discrepancies were resolved through ethical dialogue and consensus. Memos were used to document analytical decisions, emotions, reactions, and ethical tensions. My results of the coding were: autonomy affirms the patient's right to make informed decisions about their health care, including the choice to end their life under specific medical conditions. It is often justified by the principle as it allows terminal ill individuals to maintain control over their end-of-life care, promoting personal agency and dignity. Autonomy is particularly silent in jurisdictions where MAS is framed as civil liberty or human rights, and where legal safeguards are designed to protect individual choice. However, autonomy must be understood in context. As discussed in feminist and disability justice frameworks, autonomy is not always exercised freely. External pressures such as financial hardship, inadequate care, or internalized stigma can compromise decision-making. Patients often frame MAS as reclaiming control and dignity. Yet autonomy is relational. For example, one interviewee described MAS as not wanting to be a burden, revealing how autonomy can be entangled with internalized stigma. This challenges traditional and individualistic models and calls for more nuanced understanding of consent, and agency. Autonomy must be safeguarded not only procedural through consent forms and capacity assessment, but practically by addressing the relational and systematic contexts that shape choice. Beneficence is the ethical principle that obligates healthcare professionals to act in the best interest of their patients, versus non-malfeasance, which obligates healthcare professionals to avoid causing harm to patients. On one hand, MAS can be seen as compassionate relief from unbearable suffering. On the other, it involves intentional ending life, which some argue violates the physician's role as a healer. The provider in my interviews described moral distress, feeling torn between alleviating suffering and preserving life, finding meaning in helping patients achieve a dignified death while struggling with burnout. While findings show these principles are context dependent, requiring interdisciplinary dialogue, ethical consultations, and shared decision making. Access to MAS is not uniform, as rural residents, marginalized groups, and people with disabilities often encounter significant barriers. In some contexts, the availability of MAS may signal neglect rather than true expression of autonomy. Disability advocates, for example, caution expanding MAS without strengthening social supports could effectively position death as a substitute for adequate care. Upholding justice, therefore requiring addressing the social determinants of health such as income, housing stability, and availability of palliative services, and ensuring that policies remain culturally responsive and protective against coercion. These examples reflect the emotional urgency and ethical framing used in advocacy communications. The posts that I examined often emphasize patient-centered care, the right to die with dignity, and the need for compassionate policy reform. The prominence of dignity and choice in these posts align with the thematic saturation found in interview data, reinforcing the ethical continuity between public discourse and personal narratives. The frequency suggests that dignity was the most salient theme in public-facing advocacy materials, followed closely by choice and pain. The prominence of availability underscores ongoing concerns about equitable access to MAS services, particularly across geographic and socioeconomic lines. Participants consistently framed MAS as a means of preserving dignity and exercising personal agency. The theme, dignity and right, is frequently coded with rights to choose MAS and empowered, suggesting that the ability to determine the tone of one's death was experienced as final act of self-respect. Participant 1 stated, being able to choose your final chapter is a powerful act of self-respect. This sentiment was echoed by participant 9, who described their grandmother's decision as the way to leave with dignity and not be remembered as someone who was trapped in her body. The theme relief of suffering emerged as a core justification for MAS. Participants described physical pain, emotional exhaustion, and existential distress as catalysts for considering or supporting MAS. After battling cancer and finding out all options had been exhausted, my participant 3 said, it's not about giving up, it's about choosing how I go. Participant 10 described their brother's experience with advanced illness as devastating, noting that MAS gave him a way to exit with dignity. Empowerment was also extended to caregivers and family members who supported MAS decisions. Participant 9 described their roles as loving her enough to let her go, highlighting the relational dimensions of empowerment. Participants frequently discussed the emotional and logistical toll of MAS on families. The theme family burden encompassed caregiving responsibilities, financial strain, and psychological weight. Participant 1's son stated, I've taken on more caregiving and decision making. My sister has stepped back emotionally and physically. Anticipatory grief was also prominent, with participants describing the complex process of mourning before death. It gave her emotional relief knowing she had a choice. For me, it gave me a chance to begin the grieving process before she was gone, and now a complicated kind of mourning. Participant 4 shared while thinking about the loss of her mom after a long battle with MS. Patients often see loss of autonomy and dignity with more than physical pain. Families experience complex emotions such as grief, relief, guilt, and conflict. Providers face burnout and compassion fatigue. One patient described the existential relief of simply having MAS as an option, even if they didn't use it. Families spoke on both gratitude for peaceful death and lingering disenfranchised grief. These emotional landscapes are ethically significant. That MAS is not just medical or legal, it's profoundly psychological and relational. Policies must integrate counseling, family dialogue, and provider support. I propose compassionate pluralism as respectful engagement across diverse moral, cultural, and religious perspectives. This principle bridge polarizes debates, recognizing shared values of compassion and dignity, even when conclusions differ. For providers, compassionate pluralism means institutional support for conscientious objection while ensuring patient access. For families, it means dialogue that honors differences without fracturing relationships. From my thesis, Legal and Policy Frameworks, Medically Assisted Suicide is governed by diverse legal frameworks across the globe, each reflecting distinct ethical priorities, cultural norms, and healthcare systems. Comparative analysis reveals both common principles, such as autonomy, informed consent, and procedural safeguards, along with significant variations in eligibility requirement, criteria, implementation strategies, and public acceptance. Understanding these legal arguments is essential for evaluating the ethical and practical dimensions of MAS. In the U.S., autonomy and safeguard are dominant. In Canada, they expand eligibility to non-terminal conditions, raising disability justice concerns. Switzerland's minimal regulations raise questions about suicide tourism, as seen with the sarcospox. The Netherlands and Belgium integrate MAS into mainstream healthcare with strong safeguards. These differences reveal that laws alone do not ensure ethical soundness. Cultural narratives, healthcare infrastructure, and systematic equity matter equally. Implementation challenges include uneven provider participation, geographic disparities, and resource limitations in capacity assessment. In conclusion, MAS is not simply about individual choice or legal framework. It's a multidimensional phenomenon shaped by ethics, psychological, and social context. My research reframed autonomy and justice in relational systematic terms. It centered lived emotional experiences, ensuring patients, family, and providers are part of the ethical conversation. It introduced compassionate pluralism as a new framework for dialogue and policy. By centering both experience, relational autonomy, and justice, my work offers a foundation for more compassionate, culturally responsive, and ethical grounded approaches to end-of-life care. This research demonstrates that medically assisted suicide is not simply a matter of law or medicine, but a multidimensional ethical, psychological, and social phenomenon. One that, I'm sorry guys, I didn't read all this apparently. Thank you for your time and engagement. I welcome your questions and look forward to discussing how these findings can inform both scholarship and practice and help communications.
Okay, thank you. That was wonderful. Good job. We have some time for questions, and you're not expected to read it. You wrote it. Just as good. I did. Any questions either from our Zoom friends or from our audience here? Not all at once, one at a time.
I feel like everything was so well said and well put together. Like I can't think of anything to ask about.
I don't know. So you did this, and this is just more of an opportunity for you to kind of explain the context a little bit more, because you did this in pursuit of a communication master's degree. So, but I know that when I got it, because I think I was on the committee, if I remember correctly, so all the way back in the fall. It was a little surprising that this was a topic that you were kind of looking at through the lens of communication theory and such. So I was just kind of curious if you could talk a little bit about how the communication theory side of it, kind of got you into this topic or vice versa.
My principle is one that isn't necessarily tied to communication. It's I chose it because I feel like so much of what this topic included needed to be addressed by the patients. I tied it in to my communications because so much of it is communicating. The patients have to communicate with their providers, they have to communicate legally with any of their lawyers or the state. If that's one of the cases, they had to fight to be a participant. So it was basically, I chose this because it was something that means a lot to me, and I made it work for communications. I decided if I was going to write a thesis, I wanted it to be something that I enjoyed learning about or that I felt passionate about. And unfortunately, I've had a lot of experience with suicide in my family, along with terminally ill parents, grandparents, and aunts and uncles. But I know if this had been available in Arkansas or Texas, they probably would have selected that as an option rather than going through the treatments and dying without them doing it. So that's why I did.
Okay. Yeah. No. Yes, Dr. Khan.
I guess I could add to that your reply. I think it is very important in the communication when it comes to setting the public policy. So I think that it is very related.
Yes, and public policy, unfortunately, is the majority of the states that have accepted this into a policy and is allowing it are very liberal. I don't know that we'll ever see it in the South for a very long time because it's a very more conservative Bible Belt. But there are actually people who travel if they're ill enough. I have found that they can relocate to a state and live long enough to become a resident in that state, then they can qualify. So there are actually people who move their entire families so they can qualify for this. One of my participants moved across the border to Canada. She had had an MS her whole life, and she was tired. And I actually interviewed her on Friday, and she passed away the next Wednesday. She passed away.
I don't have a religion currently, but when from religion side, as a Christian, suicide is not allowed in their religion. So I guess that might be one of the big reason is that my question is, assisted suicide is also considered a suicide. You did not kill yourself.
Right, and that's kind of something that was addressed actually during my thesis topic. The stigma when it comes to suicide is different to me than medically assisted death. And I hope that through dialogue and policy reform and things like that, that can take place, that maybe it will change. Because I don't think that suicide, because you have a mental health situation and you choose to take your life, is the same thing as knowing that your last 6 months of life are going to be bedridden and your family's gonna have to take care of you, and that's not what you want, so you choose to end your life. And maybe I may be looking at it differently than somebody else, but that's my view of it. But the stigma when it comes to suicide is horrific, and I would hope that policymakers would understand and maybe be able to change that and give individuals who just want dignity in their life the opportunity to pass on without the stigma of suicide.
Any other questions or final thoughts or anything? All right, in that case, we'll say thank you again to Leslie, appreciate it. And we will have our next colloquium, I think possibly next week. I should have looked that up. But I think we might have it next week. We do have our nonprofit fair next week on Thursday, so that should be exciting as well. But all right, thank you, folks. Take care.